So I've been tasked with talking about shoulders and specifically arthritis related to it. And so a little bit about myself. I grew up in Northeast Ohio. I did my undergrad in Cleveland, Ohio, and my residency in Columbus. I did two fellowships, a minimally invasive arthroscopy fellowship in Miami. I was fortunate to work with the Miami Heat, and then a shoulder and elbow reconstruction fellowship, and been in practice a total of 10 years now. So as I mentioned before, really arthritis is the loss of soft cartilage that covers the ends of the bones. And there's a variety of different causes for this. It can be either degenerative or the most common osteoarthritis, inflammatory arthritis like rheumatoid or psoriatic arthritis, if you have bad trauma, or for specifically what we can see with the shoulders for patients with long-standing rotator cuff tendon tears, we can get rotator cuff tear arthritis. And whatever the cause is, it's a loss of the smooth cartilage at the ends of the bone, allowing exposure of the underlying subchondral bone and pain. And the shoulder anatomy is made up of three main bones, the humerus, the scapula, and the clavicle. It's a ball and socket joint with smooth cartilage at the ends of those joints. And we have four rotator cuff tendons that wrap around the top of the humerus to allow all the range of motion that we see with the shoulder. So once you see a shoulder specialist, honestly, when you have pain greater than 3 months, but if you can hear yourself cracking when you're walking around the corner, that's probably time to see a shoulder specialist. And the most common symptoms we see pain at night while trying to sleep, especially when it gets quiet and dark and cold out. Pain during daily activities affecting the quality of your life, catching and popping, stiffness, loss of motion. And the first step we do is we obtain an X-ray. The X-ray really tells us the extent of the arthritis. And the classic hallmark symptoms we see with that is loss of joint space, bone spurs, sclerosis or hardening of the bone, and bone cysts. And if we let this go for a long periods of time, it can start affecting the joint line, losing bone, and changing the overall biomechanics of the shoulder joint. So what you should expect when you see a shoulder specialist is first, you'll get a thorough medical history because a lot of the different medical comorbidities we see can really affect our decision in what shoulder replacement we use, if we should undergo a shoulder replacement, or if there's any conservative treatments that might be more effective for you. When we look at physical examination, the first thing we see is motion. When we get long-standing arthritis, and especially when it progresses, we can see loss of motion, crepitus with that, or catching and popping with it. We always want to look at the strength to see if the rotator cuff tendons are intact. We see if there's any instability of the shoulder joint or shifting as that humeral head will shift in and out of the socket. As mentioned before, we always get X-rays to see how advanced that arthritis is. But depending on what decision we're making, we'll sometimes get an MRI to look at soft tissue such as the rotator cuff tendons, or even a CT scan to look at how the quality of the bone is and for preoperative planning. So what are the available treatments for our osteoarthritis? Pretty much the same as we have for knee and hip arthritis, in that the first thing is if it hurts, don't do it. We do activity modification, anti-inflammatories, steroid injections, as mentioned before, platelet-rich plasma or PRP injections. Physical therapy helps maintain the motion, though sometimes it's hard to get more depending on the degree of arthritis. For patients who are very young and have a mild arthritis, we can sometimes do a shoulder arthroscopy. And as shoulder arthritis advances, we can start thinking about doing a shoulder replacement. So a shoulder replacement is very simply you're replacing the ball and socket with metal and plastic, and it's extremely common. The incidence of shoulder replacements is actually outpacing hip and knee replacements as our technology has advanced, and we're doing more than 100,000 of these per year. And the key is really knowing the reason we've had such huge advancements is because it was kind of slow to start with beginning. The first shoulder replacement was in 1893 for tuberculosis patients. And looking at that prosthesis, you can see it didn't do very well. And it was really took about a half a century before the design started improving. And the father of the modern shoulder design, Dr. Charles Neer, completely redesigned the shoulder replacement, looking at hip replacements, and was able to kind of get the more modern replacement we have today. And now we have more than 70 different design techniques that has truly advanced the role of shoulder arthroplasty in patients who are living with shoulder arthritis. And the more modern shoulder replacement have improved design and materials. We have different metals now, such as titanium, pyrocarbon. We try to be more bone preserving. Instead of the older stems, which had long stem that filled up the entire canal, we now have a lot of stemless implants that do a great job preserving the bone and recreating the normal anatomy more anatomical. We have modularity, meaning that we can switch from either the reverse or the anatomic without having to rip the whole implant out, which has really helped for revision surgeries. And the combination of this has resulted in improved pain relief, better function, more range of motion, and implants are lasting longer. And we have two types of shoulder replacements, unlike knee and hip replacements, because we have to rely on the rotator cuff for motion, either the anatomic or the reverse shoulder replacement. So for patients who have an intact rotator cuff and arthritis or avascular necrosis, we can do an anatomic shoulder replacement. And that simply recreates the ball and socket just as they are and allows us to get rid of the ends of the bone that have the loss of cartilage. They notice, though, for patients with a specific type of arthritis and long-standing rotator cuff tendon tears, that when they put a primary anatomic shoulder replacement in there, the function wasn't any better. They'd still have pain and discomfort. They found out that an anatomic shoulder replacement in the setting of a rotator cuff tear just wasn't functioning it very well. And you see early loosening of the plastic component with these patients. So for the reverse shoulder replacement, it takes a ball and socket and reverses them. By doing that, by putting the socket on the humeral side, we can have a deeper socket and allow the two implants to overlap slightly. That helps replicate the function what the rotator cuff does by stabilizing the shoulder and allowing the big muscles such as the deltoid, the pec, the latissimus to have better function overall and allow people to lift their arms up, which before they weren't able to without having the balance and stability of the rotator cuffs normally provide. And this was first developed by a French surgeon in 1985. And it took about 2 decades of success before the FDA finally approved it in America. But in the last 2 decades that we've had it, the design has dramatically improved, allowing better functionality, better improvements, and expansion of the different indications that we use for it. It used to be for patients with just rotator cuff tears and arthritis, and now even for patients who just have arthritis, we can even consider doing a reverse shoulder replacement because of the quality of the outcomes. So really, the design has improved dramatically. I was a shoulder fellow 10 years ago, and what we were using then versus now is completely different. Patients used to say, well, if I wait 5 years, it could be dramatically better. And I used to think, well, it'll probably be that much better, but actually has been dramatically different compared to where we used to be. Our designs have improved. There's better augmentation or filling in of any kind of bone defects, overall more anatomical design. We have patient-specific instrumentation or implants that can be made or implant guides that can be made directly for the patient. We use that from the CT software that allows us to actually take the bone, make a 3D model of it, and try different implants in it. And in the last 6 months to a year, we've actually designed patient-matched implants where we can actually design an implant from our software planning. I can hit a button, it's made in France, and they ship the implant over that we can put directly in the body, and we can essentially create exact implants we want for patients. So who needs a shoulder replacements? Really patients who are having daily pain affecting the quality of their life. Pain while sleeping at night is probably my number one indication. Loss of motion or weakness of the shoulder, and patients have failed conservative management consisting of cortisone injections, oral anti-inflammatory pills, and physical therapy. And shoulder replacement nowadays is performed either in the hospital or more commonly in the ambulatory surgery center now. Medicare has allowed this to be an outpatient procedure starting January 1st. So we're doing more and more of these in the surgery center, which have a little better outcomes from the standpoint, less infections, faster recovery, better patient satisfaction. On the day of surgery, we do a nerve block, which helps numb up that whole arm. We still put you to sleep, but that way we kind of control the pain throughout the night for the first day. Patients are usually discharged either from the hospital the next day or even the day of, depending on how well they're doing. The therapy is pretty consistent nationwide in that we do a sling for about 6 weeks. After 2 weeks, we get physical therapy going. 6 weeks, we begin unrestricted passive active range of motion. And then strengthening begins at three months. And the outcomes show that we have a dramatic improvement between 3 to 6 months, but these keep improving up to 2 years later. And most patients are extremely satisfied with the results. The satisfaction rates have been greater than 90%, and a lot of patients are able to return their pre-surgery activities such as golf and tennis. And people always ask how long these last. And really, at 10 years, the survivorship is between 90 and 95%. So, and even at 15 years, the survivorship is 85%. But the reality is those are implants from 10 to 15 years ago. The quality's improved dramatically. So we're hoping for even better outcomes as implants have improved and the materials we're using has improved. Thank you, guys.